at least do some concept maps on some concepts that I wasn't able to cover in class. So that would be to our benefit. So um, so glad we got that out of the way. Well, we're getting this out of the way today, and the concept map today won't be much. So I'll try to make that one as simple as I possibly can. Uh, let's see. Hold on. Let me. I got so many people in my other class who calls out for one reason or another, and especially around test time. And I don't know whether I'm coming or going. It's so hard to keep up with, and I know, I know, things come up and everything, but need you guys to really run me down and, make sure you take these tests so they don't, fall right on top of each other. Where is it? All right. All right. So we are in the the fifth, I'm sorry, the fourth week. Yeah, the fourth week. The topics that we'll be dealing with now is actually kind of like a part two of the urinary problems. Um, yeah, so it's kind of a part two, if you will, because as you remember, last week it was renal let's see, I believe renal transplant and I believe nephrotic syndrome, but I'm not sure about that one. But at any rate, this particular week, we're in week four, renal inflammation and reproductive system. And so we'll be talking about um, cystitis today, which is, a bladder infection. Um, but then there are some voiceovers on some other topics that we won't be able to get to today. Keep that. For example, pyelonephritis and glomerulonephritis. Um, and so those you'll listen to those at some point in time when you get a chance. I also did a voiceover on cystitis just in case people have to jump off for whatever reason. Then you'll at least have that to take a look at as well. Now, some of you might say, well, why am I sitting here on the phone if if the lecture's already in place? And I would probably say more so because each time as an instructor you get a chance to go over this information again and again. You just kind of find hopefully more or less new and improved ways of delivering the information. So um, and and of course you can ask your questions, um, so we can have a bit of dialogue going on as we discuss the information. I don't know if I like the color of that of this presentation, but the background. But anyway, so take a look at your objectives here when you get a chance. So take a look at that. Here, I think we also talk about renal stones, kidney stones, for this week's testing material as well. So care of patients with urinary problems. And by the way, this assessment will be an exam, so it does weigh more as opposed to it being a quiz. Although I always tell you to take all of them serious. All right. Um, and of course, the priority concept for this chapter is elimination. And of course, that makes sense because that's what the urinary system does. We eliminate waste. And the interrelated concepts for this chapter, of course, is comfort, immunity, and skin integrity. So you want to think about these concepts as we continue to go through the presentation. All right. So as we know, cystitis, it is an inflammatory condition of the bladder, and it usually refers to inflammation from infection. As you can remember from last term, you can have inflammation without an infection. right? But almost all, pretty much all infections means that there's some inflammation involved. In this particular case, inflammation and an infection are associated together. Um, yeah. Um, so there are also irritants that can cause cystitis. Again, as I mentioned, without infection, an infectious organism such as drugs, chemicals, and local radiation treatment. If you can think about if somebody had either cancer of the bladder, or if they had cancer in any of those the organs near the bladder that is in the pathway of the radiation, that can also cause an irritation. I mean, they do have some radiations where it's directly pointed to the organ of interest. But in this particular case, you know, you might still, the bladder still may be in that pathway, and so you will get some cystitis as well. There's also an interstitial cystitis, which is a very painful inflammatory bladder condition. And this is what I was saying with this particular disorder. Um, the bladder is inflamed, but and there's no infection, even though it says you know interstitial cystitis. It's just an inflammation, or an inflammatory condition. Um, and um, and of course, an infection can occur in anywhere in the urinary tract and kidneys. So that it can start from the kidneys all the way to the urethra, and we refer to that as a urinary tract infection. Now, there are other irritants that can cause UTIs, and think about like the feminine hygiene sprays. There's also spermicidal jellies, along with long-term Foley catheter usage without infection involved. Right. And cystitis, of course, it can occur due to other health concerns or complications, such as your pelvic inflammatory disease, Crohn's disease, as well as lupus. I want you to read page 1355, table 66.3 for factors contributing to UTI development. So take a look at that. These infections, they can be acute and they can come back. In most cases, they'll come back. Now, an acute condition is an invasion of the normal GU tract that is caused by some infectious microorganism. For one to be considered to be a recurrent condition, it will occur more than 2 times in 6 months, or greater than 3 times or 3 infections in 1 year, and this would be considered recurrent. All right. Now, you have to know or understand the different types because the treatments will vary, and so this is why it's so important to understand. You'll also must take note that a UTI can be complicated versus uncomplicated. And when we're talking about uncomplicated, these are those patients who do not have any kind of anatomical or functional abnormalities of the GU tract. These patients are without risk factors that can lead to an infection, and the treatment is likely to resolve when it is initiated for these patients. And of course, if the client or the patient is compliant with the treatment regimen, those are your uncomplicated, treated fairly easily. But then now we have the complicated type, and those involve your women who are pregnant, they're more vulnerable. You also have the male gender, diabetes, of course. Well, let me back up. So when we talk about the male gender, think about the urethra, the length of the urethra for a male and a female. With a female, the urethra is about maybe a couple inches in length. And for a male, perhaps about 6 inches in length. And so it takes a microorganism a little longer to reach the bladder in a male versus a female, and the upper structures, of course, of the urinary system. So this is why we refer to it as complicated for males, because it's a whole lot more difficult for them to get a UTI as opposed to females. And also diabetes, a CKD, etc. There's some more conditions I want you to read about as well. So these conditions can contribute to complicated UTIs. They're just harder to treat. Right. So in men, the UTI, again, would be usually complicated. And you would typically see this in our older population, or those who engage in anal intercourse as well. Now, when we're talking about this condition impacting men, it does the treatment will take longer as opposed to your usual take a 7-day or 10-day course of antibiotics. In this case, it may take several weeks or so in your men. Right. And also with men, one of the reasons why it's so difficult to treat is because they usually have some other associated issues, health issues, that makes it that much more difficult. Again, such as like your diabetes. It can cause it to take longer to fix. Now, bacteriuria, no, not bacteriuria, bacteriuria, or bacteria in the urine, occurs with cystitis or UTI. So when you take a urine specimen, you will find certain organisms in the urine specimen. Now, this bacteriuria, when it does not have signs and symptoms, because sometimes you may find bacteria in the urine, but these patients don't have the signs and symptoms associated with it. And so we refer to this as a colonization. The patients are just colonized with this bacteria, or asymptomatic bacterial UTIs. This is common in our older adults, and it can progress to an acute infection, or if someone has renal insufficiency, especially if the patient has some other health problems. And of course, it does require prompt treatment as well. Now, in terms of sterility of urine, the urinary and the GU tract is normally sterile, except the tip of the urethra. And as you guys, I'm sure, can remember, whenever you have to do a clean catch urine specimen, you always have to clean the tip of the urethra in order to get an uncontaminated specimen, right? And there's also several, in terms of UTIs, and to show you that it is somewhat a little difficult to get a UTI in some cases because of certain host, some of our defenses. It helps protect us against a urinary tract infection. For example, secretion of mucin, kind of like a mucoid type of a substance that traps these microorganisms. Also, urine pH. Depending on the pH of the urine, it would make it difficult for some organisms to grow. There's also morphonuclear leukocytes or white blood cells, urinary proteins, also prostate gland secretions of protective proteins can help prevent UTIs as well. And then, of course, there's voiding. As you all have probably been told, that after sexual intercourse, urinating can help push out, those microorganisms. Does anyone have any questions about that?
No.
Right, pretty straightforward. I need you guys to really pay attention to this slide here, and that's all I'm going to say. So when we think about the reason or other factors, in this case, genetic risk factors that can lead to UTI, we must think about what are the most likely organism? And in this case, it would be E. coli, especially in females. As you know, females should wipe from front to back. And, sometimes they may be wiping from back to front, and they pull those organisms right back into the vaginal area as well as the urethra. And that's about 90%. So that's the majority of organisms that you will culture out. Now, Candida is another infecting microbe, and it can occur if, let's say, if a woman is being treated with an antibiotic, it can cause Candida, which is normally under control because it's part of the normal flora. But because of the antibiotics, it can kind of create a super type of an infection. And so these people can acquire Candida. Now, remember, Candida is a fungal infection, right? So pay attention to that. Candida or thrush, it's basically a fungal infection. Treated normally with flagyl, by the way. And of course, a Foley catheter is the most common factor associated with new onset UTI in the care setting. And a lot of hospitals, or excuse me, not hospitals, insurance companies or third party payers will not pay for patients who have UTIs or they acquire a UTI in the hospital, which is a form of a nosocomial infection. So for this reason, what you will find in the hospital is they will try to remove that Foley as soon as possible. Sometimes it doesn't make sense because here's the thing. I mean, if you're very busy and you remove that Foley and the care team, they remove the Foley, and you don't have the staff to be able to go in after the person is incontinent and they pee all over themselves, or maybe they have a bowel movement and what have you, and they're not cleaned up timely, then those substances will destroy the skin as well. So would you rather treat a UTI? Or would you rather treat a severe skin breakdown due to stool and urine? And so, or would you just get more staff? So I think that's the cheapest, if you will, because I mean, if you think about it, if someone is being treated for a Foley, catheter or CAR T, infection, type of infection, or they have significant skin breakdown, I mean, that can cost thousands, especially the skin breakdown. So why not just hire someone, maybe people PRN that can come in and do these things? But anyway, what do I know? some of these executives, I tell you, I don't know. I don't know where they got their degrees from. But anyway, I guess that's neither here nor there. Now, whenever you hear about a bacteria having like bacterial virulence in microbiology, it essentially means the ability to invade and to infect. A high bacterial virulence required to overcome the normal defenses or immunity. You know, we have our defenses and immunity that protects us from microorganisms. And so the greater the virulence, the more infectious or likely that the patient will become infected. Those adults or people with low immunity are more susceptible to even bacteria of low virulence because, you know, they're already compromised. Now, there's also what we call referred to as an ascending infections that starts from the external urethra to the bladder. All right. And we call this cystitis. So in other words, the bacteria starts, let's say, at the tip of the urethra, and then it migrates upward and towards the bladder, and so infecting the bladder. And we call it cystitis, inflammation of the bladder with infection, of course. All right. Now, bacteria, it has a special adhesion or ability to stick, which it results in this patient receiving or having an ascending infection that can ultimately reach the kidneys, which then we call it pyelonephritis. So the bacteria has a way of sticking and climbing, you know, towards the upper urinary structures. Now, infectious cystitis, as I mentioned, can come from bowel or the vagina as well. All right. And, you know, with the vagina, the urethra is in close proximity. And so it can certainly cause microorganisms to migrate through the urethra, and then, of course, upward towards other structures. Now, other microbes that can cause an infectious cystitis, it can be a virus, it can be a mycobacteria, as well as parasites. And there's some additional causes as well that I need you to read. Now, irritation, trauma, or an instrument that is inserted in the GU system, it can impair the host. We're the host, of course, our host, the host defenses. And so, and can cause these migratory pathogens leading to infection. So, especially when you're breaking that mucous membrane, that line of defense, if you will. Now, catheters are most common, the most common factor associated with the new onset UTI in the care setting. So within 48 hours of catheter insertion, these patients get the bacterial colonization along the urethra and the catheter itself. So getting ready to get set up for an infection. It takes about a week for patients to become infected after a Foley catheter is placed. So here again, they tend to move them as soon as possible, again, which always doesn't make sense to me. All right. So we talked about women. Now, men are typically infected by the catheter itself. And so, you know, again, it can be pretty difficult to treat. All right. Now, there's also a reason that your book talks about when you have a break in a closed urinary system. You know, when you look at that whole Foley catheter system, it's a closed system. But if there's a break somewhere, then microorganisms can get in and can begin to ascend towards those higher structures. Now, the external or outside organisms of the calf can migrate through the GU system, again, which is why a catheter care, when you guys get to the your skilled nursing facilities, you want to make sure that with your care that these patients are that they are those Foley catheters. You pay particular attention to cleaning that area to shut down or cut down on infection. I believe in the hospital they do have some solutions that are specifically used for calf care that can reduce this from happening. All right. Also take a look at chart 66-7, page 1356, for ways to minimize catheter-associated urinary tract infections, or they also call it CAUTI, C-A-U-T-I. All right. Of course, we talked about the fungal infections. Now, severely immunocompromised patients, those who have conditions such as diabetes or patients who are placed on drugs that compromises the immune system, such as steroids, they are a high risk for fungal UTIs as well. All right. Now, non-infectious cystitis can result from chemical exposures from drugs such as cytotoxin, again from radiation, and some immune issues as well, especially with some of the other drugs that people take, for example, that have lupus. All right. Now, there's also a fairly, and I don't know why even, well, actually, I think it could be a test question on this. But those patients who have interstitial cystitis, is rare. Remember, this is when the bladder is inflamed. You know, you have this inflammatory condition that is going on without an infection, right? So interstitial cystitis, although rare, it's a chronic condition affecting the lower GU tract, be that the bladder, the urethra, or adjacent pelvic muscles. It can be due to some genetic immunity dysfunction. So again, no infection involved here. Women are more affected by this more than men. It is very difficult to manage or treat. When you think about some of the signs and symptoms that patients will complain of, it's associated with bladder filling or voiding. They feel like their bladder is just full. They may have frequency and urgency of urination, or even nocturia when they're up at night to urinate frequently. They may also experience pain in the suprapubic or pelvic areas, and also pain radiating to the groin, the vulva, or the rectum as well. Now, cystitis, it can be a pretty significant problem. I mean, it can be life-threatening. It can also lead to pyelonephritis, because remember, the organism will ascend and travel upward towards those higher structures, and it can impact the kidneys. And also it can lead to septicemia. Let's see, let me make sure I mark this down for our time break. Actually, let's see, talk about that. Now, a UTI is a source of infection for severe sepsis or septic shock in about 10 to 30% of cases. So in other words, if a patient does have septic shock or severe sepsis, the urinary system would be the likely source. And so they'll probably want a urine culture and sensitivity because that's where you normally find it, the problem. I mean, it can be a pulmonary, it can be a GU system and whatnot, but in most cases, it could be or likely linked towards the urinary tract system. Now, spread of infection can, from a urinary tract to the blood, can occur, and this is what we call, in other words, the microorganism is in the urinary system and it can cross over into our blood, and we call it bacteremia, bacteria in the blood, or urosepsis. And so these patients, so sepsis is, well, when you think about sepsis, it's a systemic reaction that can lead to shock. And of course, multi-organ failure because the blood vessels are so dilated, you don't get good perfusion to your tissues and organs and whatnot. And so these patients can die. Now, sometimes older patients come into the acute care setting with urosepsis. And of course, this is important. One of the most common signs and symptoms you'll see with these patients will be mental status change. Now, think about your older people. Their immune system, they cannot mount an attack against an infectious organism like we can, because the immune system deteriorates over time, over the years. And so one of the things we want to take note of is that you will see a mental status change in these patients, which could indicate urosepsis. All right. And of course, we always want to know what the organism is so that we can treat it more specifically and directly. So we get a culture and sensitivity to know what the bacteria is. All right. As far as incidence and prevalence, incidence of UTI is second only to URI or upper respiratory infection in the primary care doctor's office. So in other words, you'll see quite a bit of UTIs, and it's the most common healthcare associated infection as well. I also provided you all with some terms such as, or some abnormal, urine terms. Frequency, dysuria, and also urgency. So take a look at that when you get a chance. All right. Now, I'm going to tell you all something. And again, I'll just put it this way. This slide is extremely important. So take note of it, especially in terms of, well, anyway. I tell people this one term after another, and they still get something wrong on their exam. So I'm just going to leave it at that. Pay attention to this slide. In terms of health promotion and maintenance, there's some components of the NCLEX wherein you have to understand, of course, this disease process because you will be doing a lot of teaching. And so this is where this also comes in to play. You have to know how to instruct and direct your patients so that they can avoid this condition as much as possible. Folks, go ahead and take a break, come back at 9 o'clock. Trying to keep us on, go maybe 50 minutes and then go on break. So I will see you all at 9 o'clock. All right, everyone, let's go ahead and continue. As I mentioned to you all before going on break, think about this particular component, health promotion or healthcare promotion and maintenance, as you are trying to help your patients to avoid acquiring this condition. And this is one of the main components on your NCLEX as well, with any disease process, of course. Now, flushing the kidneys, and this is why we talk about the amount of not IV, but the amount of fluids, PO fluids, that should be taken in by both men and women. And of course, your urine, you should be drinking enough fluids, wherein the urine is clear and light yellow daily. Let's see. Also, when inserting a Foley catheter, especially in a care facility, it should be done on the sterile technique. However, at home, still as sterile as possible, or as they refer to it as a clean technique. Because you do have some patients at home that have to insert, they have to do in and out catheters because they can't completely empty their bladder, and so this technique is more of a clean approach. There's basically less microorganisms at home than there is in the hospital, so less chances of the patient getting a severe infection. Let's see, and also take a look at page 1357. There's a chart, 66.8, for ways to educate patients and methods of minimizing UTIs as well. Yes.
So with the Foley being like one of the main causes in the hospital setting to cause infection, why do the hospitals prefer? Wouldn't it be more dangerous for the system to continually straight cap the patient since you're introducing like trauma and microbes than just keeping a Foley in place?
Yeah, it's always that chance because all that continued accessing the GU tract over time, yeah, it certainly can lead to that. But at the same token, leaving it in there continuously, that can be a problem as well. A Foley catheter, I'm not sure if you all know or have ever experienced it, but can be extremely uncomfortable. It may look painless and harmless and all that, but it can be extremely uncomfortable. So, if I had to have the choice of doing an intake and an in and out catheter, excuse me, I'm looking at this text message, an in and out catheter over an indwelling catheter, I think I would probably lean towards an in and out catheter. But yeah, you're right, it can possibly lead to infection, especially when it's done in the hospital. And sometimes it is done in the hospital as opposed to just being done at home. So yeah, both you're at risk. Not sure if I've ever read which one where you're most at risk, but if I had to guess, if you're at home, it's not so bad. But if you're in the hospital and you're doing an in and out catheter, then yeah, your chances are just as probably even more higher than an indwelling catheter if it's not done right. Before I forget this, those of you who need to be checked off, you probably already know this, but Dr. Benoit just sent me this message. You'll be in room 185 at about 1 p.m. So just make sure you get there for that. Let me let her know I told you. Anybody else have a question? Or did that answer your question?
Yes.
Sure.
Yes, thank you.
I have a question.
Yes.
For us to have to go to school, do you still want us to do concept map? But she still have not told us how long we will be there.
Did you ask her about that? About how long you would be for the CPR?
I sent her an email, but she haven't responded yet.
Let me know what she says.
Okay.
Yeah, because more than likely, if you know, if you are assigned, you know, the concept map along with everyone else, it won't be anything. It won't be anything big or cumbersome. And it may be nothing at all, depending on what she tells you.
She told me, what was it? Were they Monday? Like 2 hours.
Oh,
But
2 hours.
yeah.
It'll be about
Okay.
3:30, give or take. Yeah, I probably won't assign you all anything. Well, if I did, I tell you what I'll do. I'm going to send you guys the medications for your next exam, and so I want, as a matter of fact, instead of doing a concept map today, I want you guys to work on your drugs for next week, and I'll send that to you before I let you go.
Okay.
Is that someone? Oh, so we'll do it that way.
I have a question.
And do you want us to mail it back to you or just work on them?
Yeah, just work on it, and you know, it's to your advantage, obviously, to work on it. And, yeah.
This is Melissa. I have a question. Did you already send us those in the email called urinary medications?
I don't think so. Well, I did for the last. Remember, there's a part 1 and part 2 as far as urinary. So I sent you the part 1 for the quiz you just took, and so there's one for your exam, which I haven't sent yet, but I'll send that before I let you all go.
Okay, with the quiz, can I work on it today?
Yeah, you can do it today.
Okay, thank you.
Yeah, ideally, I would like them done before class, but I mean, as long as you get it done today.
Okay, thanks.
Mhm. Let's see. As a matter of fact, those of you who, those of you who haven't done it already, I mean, I would probably take the time between, you know, 1 and when you get released. When you get released until about 5:30, I'll probably work on it then. But you know, that's me. All right. Make sure you instruct your patients as far as health promotion to avoid smoking because it does cause cancer of the GU tract. And also on page 1360, there's a chart 6610 with some antibiotics. You want to make sure you do health teachings, particularly about amoxicillin and its effect on contraception. So take a look at that. And also women of a certain age who are in menopause, they're more susceptible to urinary tract infections as well because of the low estrogen levels. And therefore hormonal replacement is essential in minimizing those occurrences. So they should take their hormones. You know, of course, they recommend women not to take these hormone replacement therapies by mouth because it has more of a systemic effect, and of course, it can lead to cancer. They believe versus more local, you know, forms of estrogen. You know. And the nurse also should ask the patients about any immunosuppressant medications that can weaken the immune system and can make these patients more susceptible to cystitis and other infections as well. And in that same chart, 6610, also take a look at the medications, Bactrim, Cipro, and also amoxicillin. It's a pretty nice chart. So with a wealth of information in it. So take a look at that. All right. And of course, being able to assess your patients is paramount. In every case, you need to know what you're looking for in order to intervene, to treat properly. So let's look at some assessment data for these patients. These patients will typically, with cystitis, have frequency, dysuria, which is painful urination, as well as urgency. You want to always assess the Foley catheters here. Whenever you do a physical examination, when you know you're going to be palpating the patient's lower belly, you always want them to void first. Get a specimen as well, but void first before you do that, because otherwise it would cause them a lot of discomfort. All right. Now, let's see. So on page 1358, there's a chart 66.9. It talks about the signs and symptoms of UTI. So take a look at that. Now, urine can be, I'm sorry?
What page?
1358. And I've also provided this information in the notes section of the PowerPoint. So just in case, if you all think I'm going a little too fast, I've noted that for you already. All right. Now, whenever you are assessing someone's urine and it looks cloudy, it's foul smelling, and it has blood or blood tinged, always think about infection, because this is not the normal characteristics of urine. There are certain risk factors for UTIs, which is on page, I talked about that already, page 1355, table 66.3. Those are some of the risk factors, so take a look at that information as well. Now, patients with Foley's can have signs and symptoms of fever. They may or may not have chills. They will likely have urinary sediments, these little particles that you might see in the urine. And of course, mental status change, especially in your older adults. Now this is very important. So if someone has a Foley catheter, let's say the Foley has been in place for about 2 weeks, and if you think that this patient might have a UTI and you need to obtain a specimen, you want to change that Foley out first and then get the urine CNS, the urine culture and sensitivity. And I'll probably hit this at some point, but when we talk, but while I'm here, when we talk about a urine culture and sensitivity, so basically you're getting a urine a sample under sterile conditions, right? And it can be a clean catch, a urine sample. And then you want, what they're doing is they want to culture that urine to see if something grows, right? And
So, sorry to interrupt.
go ahead.
So when you do the change of catheter, do you go ahead and just replace the catheter that was in and then drain the sample from that new catheter and then reattach the bag?
Well, there's a way you can actually access, there's a little port that you put one of those blunted needles into. Where, yeah, you don't have to don't break the seal for that.
Okay.
Now, sometimes you do have to break a seal, like let's say if you're irrigating the Foley, and so you do that under sterile conditions, of course.
Okay.
And so you're flushing the kidneys. Let's say sometimes, you know how when you're looking at a Foley, well, you may not know this, but maybe you do, but when you're looking at a Foley bag and it looks really maybe thick and perhaps a bit cloudy, if you will. And so if it looks like it's not draining properly, then you may want to go ahead and, of course, get an order and flush it, just to make sure nothing is obstructing, the catheter itself. Yeah. See if I can find, if you guys don't know, I'll see if I can find something to show you, because they use a blunted end, let me see something.
Isn't it like one of those big syringes?
Well, it can be, it's a large syringe, the needle, it's a blunted needle. That's what, let's see, blunted needle. It's really a big, is that? I don't like that. Maybe this is it. So, don't know if this is the best depiction of what I'm looking for, but I got another one in mind, but sort of kind of looks like this. See that blunted end?
Yes.
Yeah, and you access the port on the Foley catheter. Let me see. It's the Foley catheter collection port. Let's see. Oh, now, so let me say this to you. And actually, if you put in a new Foley catheter, if you put in a new catheter, that the bag that you use, it's a brand new bag, right? So you technically you can take the specimen from that bag at that time, right? Because as long as it hasn't been sitting there for a while, then no, you can actually take it from that particular one.
Okay.
All right, you see that? All right, there you go. You see that port right there?
Yes.
I don't know if hopefully you guys can see that. Yeah, here's the port here. So you just stick the blunted end needle in there. Let me see if maybe she'll do it. See how that urine is in the bag? Oh, that's even better because you don't need a blunted end. I've never seen one like this. Usually you have the blunted end needles, but this one you just need the syringe with the tip. That's really neat. And about 10 cc's is what you need, by the way.
Yeah, I've never
You never seen that? I've never seen that before. And not that you would be in danger of, sticking yourself as much with a more sharp end as opposed to a blunted end, but, it's nice to know that you don't need a needle. Anytime you're talking about a needle, there's always that risk. Let's see. Right. Yeah, so So if it's a new Foley you're inserting, and let's say as soon as you insert the Foley, you get this great return of urine, even if you didn't get a great return necessarily right off, and maybe half an hour or so it takes the bag to fill up enough for you to get a sample, you can go ahead and use that and send that for your urine CNS, because it is sterile. Until it's been in there for a while, then it's not sterile. And then the sensitivity would be basically they apply certain antibiotics to the organism. And if you'll see on the report, on the lab report, a list of R's, R as in Romeo, and S as in Sam. So R's and S's. If there's an R, it means resistant. And so you don't use that antibiotic for the patient, because that means that the organism is resistant to it, to that antibiotic. But if it says S, it means that the organism is sensitive to the antibiotic. And of course, you want to start the patient on that particular antibiotic or medication. So that's how that happens. Always want to look for signs and symptoms of an infection, such as fever. The heart rate will be elevated, and tachycardia. These patients can become septic as a result. All right. Now, if someone still has a distended bladder even after they have voided, then this will be considered an incomplete bladder emptying. And sometimes in the hospital, we may use a bladder scan to see if there's any, if the patient has, if there's any residual urine that is left. So a patient empties their urine, bladder still full, and they feel like they haven't had a complete emptying of the bladder, and you do a bladder scan, and you may note that there's like maybe a few hundred cc's. I think at a few hundred cc's, and some of you techs may know this better, but I think at a few hundred, if you detect this 300 cc's, you'll leave the Foley in, because they're retaining urine. And they might, until they, I guess, figure out, why this patient is holding on to urine, till they investigate it. So I think that there's a certain amount, I want to say like maybe 200 or 300 cc's. Now you also want to assess the urethral meatus and vaginal opening for signs and symptoms of lesions, or discharge, or signs and symptoms of an infection, because this can lead to a UTI as well. So that's all a part of your assessment. Now also, an enlarged prostate can obstruct urine flow. The prostate surrounds the urethra of the male, and if it's compressing on the urethra and you can barely get urine out of the bladder, these patients, the ability to urinate, then the urine remains in the bladder, quite a bit of it, and becomes stagnated. And of course, it increases the risk of infection as well, a UTI. The term is called urostasis. And of course, the urine becomes colonized with bacteria, because the urine is not freely flowing out of the urethra. Out of the bladder, through the urethra, and of course, in the commode. So your older patients, and also keep in mind too, when you're getting ready to insert a Foley catheter, in any man actually over the age of 50, but especially over 60s, 70s, and whatnot, because they will likely have what we call benign prostatatic hypertrophy, meaning the prostate is enlarged. And of course, when a prostate grows, it can grow outward and also inward. It's all right if it grows outward, but when it grows inward, then that's when it can begin to obstruct the flow of urine at that point. So it may be difficult, I guess what I want to tell you, it can be difficult to insert a regular Foley into these patients. And so they might use what we call a Coude catheter. It's a catheter with a more heavier tip at the end. Now, it used to be years ago that a urologist had to be the one to insert that particular type of Foley catheter. But I heard somebody say not long ago, I think a regular nurse said that they were able to insert them as well. So you certainly want to make sure that you check the agency's policy, check with the charge nurse and what have you, to determine if you can insert a Coude catheter. I didn't think you can, at this point. All right. Now, of course, when we're talking about assessment, we always continue to include our laboratory or imaging type of studies or assessment tools that we use to inform us on the patient's status. Now, urinalysis is not the best test to be used to determine if someone has a UTI in your older adults, especially with Foley catheters, not just a regular urinalysis. All right. A urinalysis is not a very specific to diagnose the UTI, but as I mentioned to you earlier, you would need the urine culture because this would tell you the type of organism and the number of colonies. Typically for a UTI, it would have to be about greater than 100,000 colonies, and you'll see that on the laboratory report, and that pretty much confirms a UTI. Not saying that's 100%, but usually that's the standard, greater than 100,000 or 10 to the fifth power. And also remember your clean catch urine specimens. We typically use, they can use 2 urine containers. I've usually seen 1, but your book talks about 2. You need about 10 mLs, as I said, as well. Now, there are other indicators of someone having a UTI. A positive leukocyte esterase and nitrate. You saw on that video when the person had the bottle with the different color codes on it. Those color codes, after you do a urine dipstick, it can actually show you if there's positive leukocyte esterase and nitrates in the urine. And so if you find that it's pretty highest in terms of sensitivity in the diagnosis of a UTI. So if you see it, there's a great likelihood that a person has a UTI, even if other things don't seem to match up or point to a UTI. There's also white blood cells that are found in the urine, or what we call pyuria. There's also red blood cells that can be found, or hematuria. And then some patients have clumps of material or cells called cast. All these can point to a UTI as well. So think about these in terms of your assessment tools. Now, as far as nitrates are concerned, your bacteria, during that metabolic process, because bacteria goes through the metabolic process as well, they can produce nitrates, and this is why we find nitrates in the urine sample. All right. And we always want to make sure we are obtaining these urine specimens the correct way, because you don't want to get false results and you're treating the patient for an infection that they really don't have, because you just don't willy-nilly just start patients on antibiotics because it can lead to super infection. Now, if the first specimen container that you obtain points to a UTI, then the second one is analyzed for urine culture. And a culture also is performed when a patient with a UTI doesn't respond to the usual treatment. Or it can be done when the diagnosis is not certain. And also to assess for sensitivity, because we want to know what we're dealing with. And we can also do urine cultures to determine if there's a resolution of the UTI. We want to see if the treatment has worked. All right. Now, Now, patients who are not cath, who have a UTI, signs and symptoms such as a fever, dysuria, new onset frequency or urgency, those who also have the suprapubic or flank pain, hematuria, with a few microorganisms in a voided specimen, can also suggest that a patient has a UTI. And because I was thinking about that, you know, what I just mentioned to you about the over or greater than 100,000 colonies, sometimes we have to look at other diagnostic features that points to a UTI as well. So don't just get hooked on, or you know, get kind of that tunnel vision and thinking that it takes greater than 100,000. It could be other assessment features to consider as well. Let's see. Now, sensitivity, when we talk about getting the urine culture and sensitivity, but the sensitivity portion, with trying to determine what the organism is sensitive to, it usually follows the urine culture when complicating factors are present, such as these patients who have a kidney stone or recurrent infection. All right. And again, we're just trying to make sure that the proper antibiotic is being used. All right. Now, so sometimes the serum white blood cells, you know, when you get a CBC on your patients, so the serum white blood cell count will be elevated. All right. And so it can be so high, what we call that is a left shift. And you should have learned that in 1650, because I'm talking to or teaching this to students in that class now. So when you have a left shift, you're looking at your CBC and you see a high number of white blood cells. The left shift just basically means that there's an immature number of white blood cells that are being produced. Basically, the immune system is trying to produce a lot of white blood cells because it detects an infection is going on, but it can't produce them. It can't produce the mature ones fast enough, so it ends up producing these immature white blood cells. Again, we call a left shift, or we call it also bandemia, or the number of bands or immature white blood cells, and so. What it basically means also is that this patient has reduced immunity, because if the white blood cells are immature, then they can't really fully do their jobs. I mean, it takes mature functioning white blood cells to fight off infections, and the immature types does not. Now, you're likely to see a left shift with those patients who have urosepsis. All right. When there is a systemic infection involved, and not, of course, not a local infection, but it has to, you usually see a systemic or effect, like bacteriuremia, bacteria in the blood. Now, other diagnostic tests that we use. Now, so a diagnosis of a UTI and cystitis is based on the patient's history, the physical examination, and laboratory data. So we're looking at a few things when we're trying to determine this patient's issues. Now, if urinary retention or obstruction of urine outflow is present, such as with the prostate enlargement, again, we might do a pelvic ultrasound or a CT scan to rule out an obstruction, such as a kidney stone can obstruct the flow of urine as well. So we may be looking for those things too. There's also a tool called a voiding cystourethropy. It can determine if urine reflux is present, because sometimes the structure of the urinary tract is as such that it causes urine to go back instead of going forward and out of the urethra. And so this test can determine if the urine is backing up as opposed to going forward. We want it to go forward and not backwards. All right. A cystoscopy identifies abnormalities that can increase the risk of infection, such as bladder calculi or bladder stone. When you hear calculi, we're talking about a stone. There's also a urethral stricture, the urinary, the urethra of the male or female. That can be a stricture. Maybe there's some trauma that occurred to the urethra that can cause that tissue to become hyperplasia, or grow. And of course, that can cause a stricture and narrow the opening. And there's some additional information there to look at. The cystoscopy is done when a patient has greater than 3 or 4 UTIs per year. I mean, we need to find out, what's going on, what's causing this. Now, before a cysto is done, a culture of the urine is done first to see if an infection is present. You don't want to insert this instrument first and then try to get a urine specimen afterwards, because you don't know if that instrument caused, if it wasn't done on a sterile technique, you don't know if it was a cause of the problem or not. So get the culture first, and then the instrument is inserted into the urinary structure, right? If an infection is present, then these patients are typically placed on antibiotics in order to sterilize the urine, in order to reduce the risk of urosepsis, especially with putting that instrument in the urethra. Right. Now, a cysto is also needed to diagnose interstitial cystitis, which is the non-infectious type. It's just more inflamed. And with this interstitial cystitis, a urinalysis will show white blood cells, red blood cells, but no bacteria, and that's the key. There's inflammation without infection, and so you will not see bacteria in the patient's specimen. Now, if someone does have an interstitial cystitis and they have a cystoscopy procedure done, it will show a bladder that has a small capacity to hold urine. Then there's also the presence of what we call Hunner's ulcers. You'll see these little ulcers throughout the bladder. You'll also see a small hemorrhages after the bladder becomes distended. And so these features are common in patients with interstitial cystitis. And so these are your tests, right? And so now what do we do to fix the problem, right? They are surgical approaches, they're non-surgical approaches. And of course, we always want to go with the more conservative approach, which is the non-surgical management of this condition. So as far as nursing interventions, we are looking to provide patient comfort. We want to teach these patients about drug therapy, fluid intake, and also prevention measures. Remember that health promotion slide that we were looking at. Now, drugs used to treat bacteriuria and provide comfort. So we use urinary antiseptics or antibiotics, such as, for example, well, in the case of a candida infection, we'll use something called fluconazole. We also use analgesics to provide a comfort, because these patients have pain. Pyridium is a urinary analgesic. It provides a relief of pain, has a kind of a numbing effect, if you will. And also, because a patient has a UTI, they have spasms of the bladder, so we give these patients antispasmodics. So it prevents the bladder from having spasms, which can be very uncomfortable for these patients. And this can cause, of course, if you take these antispasmodics, it can help the patient empty their bladder a whole lot better. Now, we also have, now, whenever you hear or read in your textbooks about first-line drug therapies, they're the first drugs that a clinician will use to treat a certain condition. And so in this case, the first-line drugs to treat bacteria in the urine, bacterial urine infections, is one called nitrofurantoin. There's also Bactrim or fosfomycin. Sometimes patients might require long-term antibiotic treatments when they're hospitalized with a more complicated type of UTI. Now, there are also those patients who have a UTI for a very long time, or they're just chronic UTIs, they just don't go away, or recurrent, or just chronic. And so what we might do with these patients is place them on a low-dose antibiotic to treat it. And they'll do this for like over a 6 to 12 month period of time, just trying to maintain that therapeutic level over a period of time. All right. Also read the section on low dose antibiotics on page 1359 for additional readings on that one. As far as interventions or how we fix the issue, we want to increase fluid intake so that urine remains more dilute unless it's contraindicated, like if someone has a condition where they can't drink too much fluid because it would put them in fluid overload. Or we want to make sure these patients are drinking about 1.5 liters of, or that they should have it about 1.5 liters of urine output, or about 7 to 12 avoidings daily. In other words, these patients should be instructed not to just hold their urine. They should be voiding as frequently as possible, getting rid of that urine that could cause, them to have more problems. Cranberry juice. Now, remember I told you how the bacteria has the ability to stick and climb and ascend. Well, cranberry juice, the way it prevents infection, it causes the epithelial cells or the lining of the urinary tract to become more slippery, right? And of course, the bacteria just cannot gain traction. And so you're able to eliminate, by way of urine, the bacteria out of the system. All right. And this can be provided, of course, to your patients who have recurrence of disease as well. Okay. Now, cranberry juices, they have also the cranberry juice tablets and capsules. Are taken greater than 4 weeks, can affect E. coli in particular, its ability to adhere to the GI tract and again climb. Now, sometimes cranberry juice, because of its consistency, it contains acid, can be very irritating to the bladder. Those who have a cystitis, and this should be avoided. Maybe just the pills would be better instead of the juice. Now, to promote comfort in patients with cystitis, to prevent irritation, we want to instruct these patients to avoid caffeine, carbonated beverages, and also tomato products as well. A sitz bath. Don't know if you all have ever heard of a sitz bath. For those of you who've been pregnant, maybe had an episiotomy, or those who have had hemorrhoids, you're told to sit in this container of warm water, and that can provide comfort to symptomatic cystitis. Also, sitting in a warm bath to urinate can also decrease the discomfort that these patients might feel. Right. As far as surgical management, surgery to remove obstructions or to repair those structures of the urinary tract where you have the reflux. They call it a vesical urethral reflux. You may have to have surgery, or a patient may have to have surgery to repair those structural problems or you may have to have a stone removed because it's blocking the urinary tract and causing an infection as well. So that's your surgical management that you see here on this slide. Now, care coordination and transition management. This section is also very important. You also want to give attention to it. Don't just be so focused on the patho. The patho is good, it's great, but you also want to know what you have to do in terms of as this patient transitions from if they're in the acute setting or maybe even a clinic setting, and how they transition back into the community. So you want to make sure you understand what your responsibility is. You always want to assess your patient's level of understanding. You want to perhaps use the teach back method as you talk about their drug prescription, how to take it, maintaining therapeutic levels. So you're taking them on time. You take the whole prescription bottle, not stop 7 days of 10. So you want to take the whole thing. Also address concerns associated with intimacy and recurrent UTIs. You want to have open, of course, conversation with your patients. Utilize your therapeutic forms of communication as you talk to these patients, especially women, and also discuss factors that can contribute to UTIs as well. Now, drugs that can cause the urine to change colors is pyridium. Whenever you take pyridium, it has an ingredient in this medication that when mixed with your body's systems or chemicals can cause the urine to turn orange. There's also urogesic. So think about gesic like an analgesic effect. Also, there's what they call medications, phenazole. I have to look that up, and I think there's certain medications that, let's see, I think they use in the treatment of UTI. I don't remember right off. Oh yeah, so these are from I guess it's from the analgesic family, like phenoxyparidine. It's just one of the other medications to provide relief from the pain or the irritation from it. Why is that there? Undefined. Oh, that's crazy. All right. So those of so yeah. So in terms of when you think about your patient education, right? So you certainly want to tell your patient what to expect, because some patients may not know that the urine will turn orange. So you want to inform the patient, educate them so they know what to expect, so they don't just stop taking the medication, because it will provide them with some relief. Folks, go ahead and come back at 10:05. I need to take care of something really quickly. All right, folks. We have completed the cystitis presentation. And now we will turn our attention to urethritis. All right. Now, of course, you know what the urethra is. And with the itis as the on the ending of the word, now we're talking about an inflammation of the urethra. It can be infectious. In other words, an organism, a microorganism involved, but it can also be non-infectious as well. It does occur in adults between the ages of 20 and 24. The most common cause is what we call an STI, a sexually transmitted disease. And of course, we treat these patients with antibiotics as well. Now, some of the causative organisms at play here is the UTI. UTI and also chlamydia, and there's some other information for you to take a look at there as well. Now, as it mentions here, the urinalysis obtained can show pyuria, or an increase in white blood cells. We do test for STIs, or sexually transmitted infections, in both genders, as well as pregnant women. All right. Now, the non-infectious urethritis may resolve on its own without treatment. Women may use estrogen creams if their estrogen levels are low, and so this can improve the urethritis symptoms. So we want to always consider the woman's age when we think about urethritis. Now, women with urethritis signs and symptoms, they will be similar to those who have cystitis, and also they have a feeling of heaviness in the genital areas. Right. Now, signs and symptoms of urethritis, these patients will have a discharge of mucopurulent or purulent material. When we talk about mucopurulent, the pus has a kind of a mucoid substance or a characteristic to it. There's also painful urination and also itching. The color of the discharge would vary, or does vary, depending on the infectious source. Other signs and symptoms may involve fever, with or without chills, urgency and frequency of urination as well. We want to always ask the patient about their history, such as is there painful or difficult urination? Is there a discharge coming from the penis or the vagina? And also if the patient experiences lower abdominal discomfort. The urinalysis will show pyuria or white blood cells without a large number of bacteria. Right? And all patients with urethritis, they would be, or they should be tested for gonorrhea as well as trichomonas, men and women. Now, an HIV test is also recommended by the CDC if a patient tests positive for an STI. So if someone tests positive for gonorrhea, then the recommendation is to have an HIV test as well, because there's a correlation. Not all the time, but it can be. And of course, we use antibiotics to treat these conditions. Now, urethritis, that was a pretty short presentation there. So,
Dr. Wade, I have a question.
yes, I was getting ready to ask you if I didn't have any questions. Go ahead.
If you have the suspicion that someone does have an STI, you wouldn't need consent for those kinds of things, but you would inform them that you are conducting that test.
You know, the only test I know of course, you know, you're always getting their consent for treatment and all, but the only test, UTI tests, an STI test that I know of that you have to get their consent for is an HIV test.
Okay.
I don't know if I've ever heard of for a regular UTI or not UTI, STI. But even with the HIV test, there's a way around that as well, because you can get like what do you call it, a CD4 count, which you don't need a consent for that. But with the CD4 count, it will show the numbers are very low in patients who are affected by HIV. So I'm going to go out on a limb and say probably not. Yeah, probably not.
Okay.
Sure. But now once you add that HIV test in there, yeah, you better get that consent. Does anyone know what we mean when I'm getting ready to say, does anyone know what we mean when we talk about urolithiasis? But I do have the presence of calculi stones in the urinary tract already up there, so I won't ask that question. All right, so when we talk about urolithiasis, it's the presence of calculi or stones in the urinary tract. We also have a term called nephrolithiasis, and these are stones that are located in the kidneys. And then we have ureterolithiasis. That's always a difficult one to pronounce. Ureterolithiasis, and those are stones in the ureter. And then you have, or rather, stones become an issue when they're in the lower GU tract, because remember, they can obstruct the flow of urine, and that could be a problem. Now, stones are essentially particles, an increased amount of particles, and an increase when there's a lot of these particles, if the number of these particles are so high, it's very difficult for them to stay in a kind of a dissolved form. All right. And so they become supersaturated. You know, you just have a lot of small particles that eventually, you know, when they precipitate, they can form a stone or calculi. Now, the most common condition associated with a stone is dehydration. And so when we know that, we automatically have to begin to think about some of your nursing health promotion and maintenance, and that is, unless it's contraindicated, force fluids, avoid dehydration and whatnot. Now, crystals are usually excreted in the urine, and very few actually develop into stones. So, and it's kind of scary when you think about it, because, you know, if the environment is appropriate for it, you know, we do urinate stones, and of course it's when they become larger crystals or stones, it's when we tend to have problems. Now, most stones are made of calcium, or they're made, or their consistency is calcium. But there are other compositions that are fairly rare that your book actually talks about. But typically, calcium would be more. like some of these patients who have parathyroid issues with the endocrine, part of the endocrine system. And, especially when they're releasing a lot of, when a lot of calcium is being stripped away from the bones and is floating around in the bloodstream. And as the blood perfuses through the kidneys with all that calcium, calcium can result, this calcium buildup can result in stones as well. So keep that in mind when patients are being treated for hyperparathyroidism. All right, so we'll get into that. I don't know if that's if not the next test, maybe the test after that, but I think it might be the next one. That may be a quiz. Now, formation of stones involves supersaturation of urine with calcium or uric acid. They become more crystallized, and later they become a stone. Now, the other condition, as far as formation of a stone, is called a nidus, N-I-D-U-S. It's a deposit of crystals associated with an infection. So, these are located along the lining of the kidneys and the urinary tract as well. But don't worry so much about that particular one. But it's just different ways that these stones can actually form. All right. Now, also, if the environment within the urinary system is as such that stones can be formed, there are certain environments that we want to try to avoid as much as possible. For example, high urine acidity or alkalinity, either extreme. Can also cause stones to develop. Certain drugs, such as corticosteroids, there's some additional drugs there to consider there as well. A decreased urine volume can contribute to stone formation as well. So again, we have to keep these patients hydrated as much as possible. As far as some metabolic examples that can lead to stone formation, when there's an increased amount of calcium that is absorbed through the GI tract, something we call hypercalciuria, where you have a lot of calcium that eventually ends up also in the blood. And again, it circulates through your kidneys, and it is this excessive amount of a calcium that gets filtrated through the urine in the form of a stone as well. So there's just a variety of ways these patients can develop a stone somewhere in the GU tract. Any questions so far?
One question. I don't know if this counts, but like if someone has too much like from vitamin C and stuff, does that form stones only in like the kidneys, or could that happen here too?
I think I read something about that a while ago, but I can't, let's see, right off the bat, I can't be sure. But I do remember reading that a while ago. And I think it's due to, vitamin C is, of course, ascorbic acid, and it may be due to the acids itself. Remember, we talked about a high acidity or high alkalinity can lead to kidney stones. So I think that's what can lead to these renal stones. And again, long-term use, it seems to be more of those patients are more at risk.
Yeah.
Yeah. I never thought about the ascorbic acid because I always think about vitamin C, but you don't think about, its its name, chemical name, is ascorbic acid.
Yeah, I don't remember if I looked for something else, but I remember it causing stones.
Yeah, definitely. I'm thinking it speaks more to the acidity that is created as a result in this case.
Okay.
Yeah. That's what. Of course, that doesn't mean you don't take your ascorbic acid. I guess you just can't take, but so much. What I also should have talked to you all about as well as I look at the slide. Now, these stones, they may occlude the ureter. Those two tubes that are coming down from the kidneys before they connect to the bladder. And of course, if one of those tubes get occluded, the urine will begin to back up into the kidneys, and all that extra fluid in the kidneys will develop into what we call a hydro, meaning water, nephrosis kidney. So hydronephrosis may occur if this is not addressed or dealt with. And so when they do like a kidney ureters, bladders, form of an X-ray, they will see that there's this fluid on the kidneys, and sometimes they call it like a mild, a moderate, or severe hydronephrosis. If it's moderate, heading towards severe, I mean, all that extra fluid volume can destroy the kidney structures. And so you want to certainly make sure you get that stone cleared. Now, pain is excruciating with ureteral spasms. And so it can actually be the pain can be so severe, it causes these patients to go into shock. It is that painful. And of course, when you think about hematuria, when those stones are actually moving along the GU tract and it's scraping the lining of the epithelial cells, causing hematuria. And that's why these patients with stones have hematuria, right? The urethral. All right. Now, so we talked about the metabolic risk factors of dehydration. Now, this is very important. Patients who, how sometimes when you read some of your test questions, and it asks you which of these patients are more high risk of developing renal stones. So you always want to pay attention to that, because you have to be able to identify those types of patients. Can help in your differential diagnosis as well. So patients who are white, obese, and have diabetes or gout are at higher risk of renal stones. Certain vitamin supplementations, the question you just asked, may be connected with stone formation as well. So that was a good call on that one. Other issues that can cause stone formation, you have your GU obstruction, but what if there's like a structural problem with the the passageways of the GU system, causing urine to be more stagnated, and those crystals can form. Also, inflammatory bowel disease can lead to stone formation as well. Now, they talk about diet is not considered a risk factor, but too much calcium and vitamin D. Of course, vitamin D is necessary in order to be able to absorb calcium. So too much vitamin D, calcium, and also an increase in ascorbic acid are implicated in stone formation. So yeah, that again, that answers your question.
Oh.
Yeah, you'll find that in my in the notes as well. So that was a good catch with that one. I forgot I had written that. All right. As far as the incidence and prevalence, it varies with geographic location, race, and family history. So about 12% of adults will have at least one episode. Again, very painful. Stone formation is higher in men, except for the struvite. Now, struvite is also a type of a stone. You know, you have your calcium, but struvite is also a type of a stone. And especially in white and obese males, you will find a higher incidence of stone formation. And of course, recurrence is always possible. If it happened once, it can happen again. But I understand it's so painful, actually, that you'll find that when your patients are admitted to the hospital, they have to be given hydromorphone or Dilaudid. That's how painful it is. And Dilaudid is probably the most powerful, one of the most powerful opioids that you can take. All right. Now, as far as what are we looking for? What is the assessment information we need to take as we assess our patients? What will we see? All right. So we always want to ask about the history of urologic stones. We want to think about what kind of foods they're eating, the supplementation, minerals history. And the major symptom with this is renal colic. In other words, you have this pain. Renal colic is essentially renal pain. And this renal colic is sudden, it's unbearable, as you can see here. These patients, I mean, it's so painful that they have nausea and vomiting. They become pale, a pallor. Diaphoresis is often present with this pain. So as you can see, that's quite the physiological response to this condition. We want to also assess these patients' urine output because it can, block off, flow of urine. The different tests that we will use to help in this assessment is the urinalysis, a white blood count, especially if they become uroseptic. A CT or KUB, kidneys, ureter, bladders. It looks at the kidneys, the ureters, and the bladder. It's a kind of an X-ray, which may be indicated here. These stones can also, they typically like to use a strainer to catch these stones because you want to be able to analyze them. Because that this is, they can determine that, hey, you developed the stone because your urine is mostly acidic, and there perhaps are some therapies that can not neutralize it, but kind of move it in a more favorable position or condition. Right. Now, if the patient has flank pain, the stone is likely going to be in the kidneys or the upper ureters. If the stone is in the bladder, then signs and symptoms will consist of flank pain extending towards the abdomen, or it can radiate to the scrotum in the male, the testes in the male, or the vulva in the woman. Now, when the stone starts migrating or moving, this is when these patients will experience their greatest pain. A stationary stone in the kidney or the staghorn portion isn't really moving, and therefore it doesn't cause as much pain. So sometimes these stones, when they're not moving, then you won't have as much pain, obviously. Now, once the stone reaches the bladder, signs and symptoms of frequency and dysuria become present. Right. Now, also, when these patients experience anuria and oliguria, Anuric, of course, meaning not urinating at all. And oliguric, they are urinating about 400 cc's within a 24-hour period. It means that obstruction is possibly at the bladder neck, or urethra is blocked as well. When someone has a GU tract obstruction, then of course it's a medical emergency, and so they should be treated stat. Right. We always want to look for bladder distension. The patient may appear pale, ashen in appearance, diaphoretic, as I mentioned over here as well. The pain is excruciating. We want to observe their vital signs, in particular, the increase in temperature, blood pressure, and heart rate. Especially when they have an infection, you'll see these types of symptoms. Now, if they develop shock as a result of this condition, you will not have an increase in the blood pressure because the blood vessels are more dilated in shock, and so you'll see more of a hypotension. And so you should be thinking septicemia in these cases as well, or because the pain is so severe, causing shock, that could also inadvertently affect their blood pressure. Now, when we obtain a urinalysis, it does provide certain pieces of important information, especially regarding specific gravity and osmolarity. So essentially, this talks about the fluid status or hydration status of these patients. So if there's a high osmolarity or a specific gravity, then these patients are probably dehydrated, which can be a cause of this stone formation. All right. Now, the pH of the urine may tell us about the type of stone. For example, a urine pH that is high in acids, it has a what we call, well, if the acids are high, it means that the pH is low. And that's kind of almost a little confusing, I suppose. But so you have a lot of acids, a lot of acids in the urine. And so your pH would be like really closer to that lower range of maybe 3 or 2 or something like that. So the type of stones you may find in this respect is like your uric acid or also cystine stones. And again, they want these patients to strain the urine so that they can analyze the stones. And so in this case, then it would let them know that, so this patient has a acidic urine. Now, there's also the high alkaline urine content or high pH that results in calcium phosphorus type stones, and also the struvite stones type of stones. Now, 24-hour urine analysis can show a saturation of a particular or common stone. A urinalysis might show a smoky or rusty colored urine or hematuria because the stones, again, they scrape the lining of the urinary system, causing injury and trauma. And so you see this bleeding as a result. Let's see, I told you about the staghorn. Now, I also talked about, I believe in cystitis, an infection would show an increase in cloudiness and turbidity, so the urine won't be very clear. A microscopic analysis of the urine might reveal the stone crystals, and so the urine would have to be analyzed. Also, serum or blood might show an increase in minerals like your calcium, your phosphorus, etc., especially in your endocrine conditions. And this can contribute to stone formation as well. You might find also an increase in your white blood cells because now an infection is now present. And a CT scan or X-ray can show the location of the stone as well, so because you may have to retrieve the stone. Any questions about that so far, what we've covered?
No.
No, thank you.
Yeah, I don't think this one is all that. It's not really a difficult, system to cover. Actually, at least in my mind, it isn't. All right. So now, so we know how to assess it at this point. And this is how you guys should be addressing these disorders. Um, so we want to know what the normal anatomy and physiology of the system is all about before delving into the patho. And then, of course, then why? Well, why does it develop? What's the cause of the etiology, if you will? Who does it affect? Incidence and prevalence. What group? What population? Which can be very important, and testable material, of course. And then, of course, we get into our assessment. And not only do we look for a variety of signs and symptoms through our senses, but we also use a variety of tests that helps us in our assessment to confirm the diagnosis of these patients. And of course, at this point, then we want to get into what do you do? What is your nursing responsibility in this regard? Always ask the question, what is my responsibility? Because everyone has their responsibility, physicians, nurses, and so in this case, what do you do? Now, what did I? All right. So I think I mentioned this earlier with, I believe, cystitis. So the nurse's job is to provide comfort for these patients, prevent infection and an obstruction, because we want to preserve their kidneys. If the stone is very small, let's say less than 5 millimeters, it will likely pass through the system, and so probably unnoticeable. Now, the larger the stone and higher up it is in the genital urinary tract, the less likely it's going to pass on its own. So you may have to there's certain procedures like a lithotripsy where you break up the stone into particles where you can void it out. Now, patients should strain their urine in order to capture the stone, because the stone should be sent to a lab for analysis. All right. Now, these patients, they to relieve the pain and to facilitate passage of the stone as well, pain medications will certainly be required in the form of an opioid, especially the first 24 to 36 hours. These patients will have severe pain. And so in order to get the fastest relief from this pain, then opioids would be warranted here. Now, NSAIDs can be effective here as well, although you have to be very careful about NSAIDs because they do affect renal perfusion or the autoregulation function of the kidneys, especially those patients who already have some kind of renal dysfunction. So be very careful when administering NSAIDs, maybe for a short term. And also the problem with NSAIDs is that one of the side effects is that it can cause bleeding because NSAIDs, like your aspirin, it inhibits platelet, it inhibits an increase in platelets. And so these patients are at risk for bleeding. Now, pain medication should be given on a regular schedule. In other words, when you look at a medication record, there's a portion that deals with your routine medications that are given around the clock. The patient doesn't have to ask for it. It's just routinely scheduled. And there's another section that's a different color on the electronic medical record that it deals with your PRN medications. And so you give as needed. That's what PRN is, of course. And so with these patients, especially in the first couple of days or so, you want them to your clinician will provide these pain medications on a more regular schedule in order to get better control of the patient's pain. Certain drugs like your spasmodic type of medications, your propylene medications or bromide also can provide more relief for these patients. Propanthyline. Also, we want to avoid overhydration or underhydration for these patients because we do. This will allow the stone to pass with less pain. So we want to hydrate them more adequately without either extreme. Now, there's certain stones that are associated with infections, and so like your struvite stones, which are rare, but they are associated with infection. And so antibiotics will likely be prescribed, especially, once they analyze the stone and it is noted to be a struvite type, then an antibiotic would be administered. The organism is Protease mirabilis klebsiella. It's a urease producing organism, and within stone, it makes the urine more alkaline, and so that sets the patient up for more problems, especially with an alkaline environment. Now, drugs that aid in stone expulsion, so we think about the drugs such as your thiazide, diuretics, your allopurinol. These drugs combined with an increase in fluid intake, they can lead to a urine volume. Well, the urine will become a little less acidic. It can decrease their urine pH, and the volume, urine volume, and a decrease in urine pH would be helpful in this case. And it also helps to just excrete more of the stone fragments from your patients, and of course causing less pain. Now, for kidney stones that are secondary to what we call a hyperoxalate type of stone, allopurinol is given to treat this condition as well. All right. Now, a beta blocker or a calcium channel blocker, these drugs have an effect on the smooth muscle portion of your the ureters, all right? And so given these drugs, actually it dilates them. And if you can dilate the smooth muscle portion, again, within the ureters, the stones can pass a whole lot easier. I know these medications are typically given for cardiac patients, but these drugs actually are not cardiac specific per se, but it also can affect other structures that have the smooth muscle portion of the structures as well. All right. Now, also the drug citrate helps make the urine more alkaline. And so if you have a patient who has a more acidic environment, giving them the drug citrate can help to alkalize the urine. Now, this can lead to dissolved uric acid stones, right? So the citrate is used to make the urine less acidic. And this affects, it helps the kidneys to get rid of the uric acid, thereby helping to prevent gout and as well as kidney stones. Now, this medication can also prevent and treat certain metabolic problems such as acidosis caused by kidney disease. And you will see sometimes on your medication list with patients who have a renal disease, they also prescribed citric or citrate because these patients are mostly in acidosis anyway. Now, before the citrate is given, remember the stone analysis must take place first. We got to know what we're dealing with. So you don't want to treat it before you know what it is we're dealing with. Now, if the stones do not pass in about 1 to 2 months, then it probably won't. And so the patient will have an increase in not only pain, but also they may develop an infection as well. And so now we have to do something. We have to do something to remove these stones. One of the ways we do it without doing actual surgery is the lithotripsy procedure. This procedure uses lasers, sounds, or shock waves to actually break up the stones. And so before doing this procedure, you always want to hook these patients up to a cardiac monitoring device. And there's also a fluoroscopic observation of the structures as you insert your instruments so that you can observe what is actually happening to your patient. But take a look at page 1364. It will provide you with some additional information about this particular procedure. One thing to keep in mind, or a couple of things, is that these patients, because of these this device, the lithotripsy device, they might develop bruising to the flank areas, especially on the affected side. And so, as a nurse, you can apply some cold compresses to the area for symptom relief. The bruising caused by this procedure is something you just want to educate your patients about, that it will resolve. It takes some weeks to resolve, but it will resolve. All right, so just make sure you let your patients know so that they don't be alarmed about that. All right, folks, go ahead and come back at 11:05, and we'll resume. Oh.
touch it. No, ma'am. Do you want to stay with Mama?
Yeah.
Oh.
Beep.
Is Miss Scott on? Seems like she's trying to go into another chat room, rather Teams meeting.
She was showing a minute ago.
Yeah, I thought I saw that too. Let me see. It was, oh,
She said she couldn't get in.
she is in?
I'm in. Thank you.
All right. Let's see. um, all right. So let's go ahead and get started again. Not much else to go, you know, as far as this condition, a disease condition here. Let's see, where am I? All right. So we're still dealing with the, well, at this point, we're dealing with the surgical management of patients with stones. We previously discussed non-surgical methods, such as drug therapy and lithotripsy procedure, and now the surgical management. Now, whenever you guys hear a surgical approach called a minimum invasive surgery, or M as in Mary, I, S as in Sam, it's just we're not opening the patient up to perform any type of surgery. And of course, with this particular surgical approach, patients they heal faster. They basically recover a whole lot faster because you're not cutting into a whole lot of tissues and nerves and muscles, and you know, using these retraction tools and all these things. So these patients, they just it's minimally invasive, as the word says, speaks for itself. So now there are a few minimum invasive surgery techniques that are done. For these patients, you have your stenting of the ureters. You have the ureteroscopy, you know, inserting a scope to visualize the ureters. There's also a percutaneous ureterolithotomy, There's also a percutaneous nephrolithotomy. And so on page 1364 to 1365, take a look at that for additional information regarding procedures and your nursing responsibilities, especially with respect to pre-op and post-op care. You want to know what you have to do. And again, it should make sense to you. Now, when we use a stent dilates or it makes the large ureters, it makes the ureters larger in order for the stone to pass. That doesn't even sound right. So dilates and dilates. Ureters larger to allow passage of stones. Now, the ureteroscopy procedure, it allows the stone to be seen or retrieved, and they retrieve it with like a grasping basket. The basket looked like, I guess, little, fingers or whatever, and they're able to insert this scope into the ureters to visualize the stone, and then grab the stone and pull it out. So that's another way. As far as the percutaneous urolithotomy and the percutaneous nephrolithotomy, it allows removal of the stone through the skin. And so with this particular case, we want to monitor for complications such as bleeding from the site or through a tube. This procedure can also lead to a pneumothorax. So we're looking for respiratory distress with these patients. It can also, because it's an invasive procedure, albeit minimal, can cause an infection. If there's a nephrostomy tube that is left in place to drain the urine, we want to assess the tube for volume because urine does come out of these tubes. We want to look for blood in the urine, especially bright red blood. You don't ever want bright red blood in any case. You can expect some blood in the urine in the nephrostomy tube drainage for at least the first 24 to 48 hours. Now, dressing changes are sterile, and the physician might order for flushing of the tube. Usually when you flush a nephrostomy tube, you're not flushing, because they have these stop cots on the tubing, and you're not flushing the tube, you're not flushing in the direction towards the kidney, but you turn the stop cot in a way that you're turning off to the kidneys, but onto the bag. And so you're flushing the line to flush out any kind of contents that would cause the tube to be clotted off, because you don't want to impede the flow of urine. You know what? I wonder. Take a look at this one. It's a pretty short one. I think this one should be pretty good, a pretty good example. Let's see. I don't know if I like that one. I wanted the one with the stop card. How to take care of the stop card. I don't like these. Well, maybe it's a good one. I don't know. Well, let's see if we can watch this one from this point. I think this might be a pretty decent one. Let me see. Uh-oh. Nope, don't want that. If I do this, I want you to be able to hear it too.
Whenever it is 2/3 full to prevent urine from flowing back into the kidney. During naps or sleeping at night, a larger drainage bag should be used. Keeping urine bags lower than your kidney prevents backflow into your kidney. Each morning upon waking and every evening at bedtime, you will need to change out your bag. First, gather your equipment. You'll need a clean drainage bag, 2 alcohol pads, tape, securing straps if you're using a leg bag, gloves, and a 60mm syringe. Wash your hands thoroughly with soap and water. If you have a stopcock, turn the stopcock lever to the drainage bag so it is pointing away from you and towards the bag. Disconnect the drainage bag from the tube. Put the used bag aside. Swab the end of the nephrostomy tube and the new bag tubing with an alcohol pad. Connect the new bag. Turn the stopcock lever back on to the drainage bag so it is pointing towards the clear flushing port. Secure the drainage bag. Secure a leg bag to the calf, thigh, or waist with tape or straps. Secure a night drainage bag to the side of the bed so it hangs below the leg. Wash the bag. Wash your hands every 7 days. Using the step or leaking, it should be changed sooner. Flushing your nephrostomy tube.
All right, I guess this, yeah, so this is what I'm talking about here. So this is the 3-way stopcock. All right, and so when you're flushing the tube, I just wanted you to see how we flush these tubes.
Mucus and fiber may obstruct the flow of urine from the nephrostomy tube. Your doctor may want you to flush the tube with normal saline. A prescription for the saline will be given to you upon discharge. The radiologist who placed the tube will inform you if you need to flush the nephrostomy tube, how often to flush, and with how much fluid to flush with after your tube has been placed. Flushing is used to keep the nephrostomy tube clear of debris. To flush your tube, first gather your supplies: a 5 to 10 millimeter pre-filled saline syringe, an alcohol swab, and gloves. Thoroughly wash your hands with soap and water. Turn the stopcock lever off to the drainage bag so it is pointing away from you and pointing towards the bag. Swab the injection port on the stopcock with an alcohol pad. Attach the saline syringe onto the injection port. Use a new saline syringe every time. Slowly push in the saline. Do not pull back. If you cannot push in the saline, check the position of the stopcock and the tube for kinks. If you still cannot easily...
All right, real quickly, so I guess the big thing, usually they didn't allow us to flush towards the kidneys, but I guess in some instances you can. But when you turn the stopcock, this is the stopcock here, when you turn it off to the bag, so the bag is down here, so it means it's off to the bag, but it's on to this direction. So when you inject the normal saline in the system, the fluid will go towards the patient, thereby flushing the line out, which you don't want to apply too much pressure, of course. But say if I was to turn this stopcock around to where it was pointing this direction, so when I flush it, it'll flush out this way, this direction. So wherever this point is, or this lever is, the flow or the flush will go in the opposite direction of wherever this is, this little piece as far as part of the three-way stopcock. So in this way, the flow of saline will flow towards the patient, trying to get rid of the mucus and the fibrin, which can clot off the system and back up into the person's kidneys, causing hydronephrosis and destroying the kidney structures.
Slowly push in the saline. Call your doctor. Remove the syringe and dispose of it in the garbage. Move the stopcock lever so it is pointing toward the flushing port. Check for urine in the tube and/or drainage bag. Wash your hands and apply gauze and secure the tubing connection.
So that's all I wanted you to see, just to give you an idea of what a nephrostomy tube would look like. Any questions about that? Again, you never force it. That's the key, you never force. Let's see, where am I? All right, so what we want to teach our patients is to maintain hydration in order to avoid the supersaturation of these particles. We want to strain all urine for fragments, and also teach them how to prevent stones via dietary changes as well. As far as preventing infection control helps to prevent infection, urosepsis from invasive procedures. So antibiotics before the procedure is done or it was performed, either for the existing infection or potential infection. We want to maintain fluids and proper nutrition to decrease risk of infection, especially with the struvite type of a stone. And take a look at page 1365 for antibiotics used such as a broad spectrum type of antibiotics. There's some additional information there. Culture the urine performed 48 hours after completion of antibiotics. And the reason we do that, we want to culture the urine 48 hours after you complete the medications, is because we want to see if the urine has been sterilized by the antibiotics, if it has worked, in other words. All right. Now, there must be a certain concentration of antibiotics in the urine in order to kill the bacteria. If not, the organism will remain, and so you would not eradicate the organism. Now, evidence of new infection of a new infection might cause fevers, chills, and also mental status change. And so in this case, we will have to order a new culture and sensitivity to see what the other offending organism is. So whenever you see a patient with possible urinary tract infection, you know you have been treating them before, and all of a sudden they develop a fever and whatnot, there's always a chance that there's another organism at play here. Now, patients with a Struvite stone need monitoring for long-term for infection, because again, with this particular stone, it usually accompanies that Klebsiella, protease mirabilis Klebsiella type of pneumonia. And so with these patients, you want to check their urine on a monthly basis, and so follow-up is underscored here. Now, long-term antibiotics can cause resistance over time and make antibiotics less effective. And so Lithostat and Hydrea antibiotics are often used. And this is one of the reasons why we want to make sure when we get our urine cultures that we get them properly, because you don't want to just put people on antibiotics and they don't have to be. I sometimes hate course key. Now, patients who are taking the medication called Lithostat, they should have their creatinine levels evaluated. And if their levels rise greater than 2, then you want to discontinue the medication because it does have an effect on the kidneys. As far as nutrition is concerned, these patients should be given adequate calories with a balanced diet from all food groups. We should force fluids or increase fluid intake of about 2 to 3 liters per day in order to lighten the urine and dilute it if there's no contraindication in that. You always want to think about a contraindication about the therapies that you're administering. In ordinary circumstances, it can be good, but otherwise, it may not be. As far as preventing obstruction, we want to increase fluid intake to about 3 liters per day. We want to assess your patient's intake and output because fluid hydration will dilute the urine and prevent dehydration. And of course, the urine outflow will be increased, and it will decrease the time for crystals to form. And so this will ultimately prevent an obstruction from stone formation. Now, major interventions to prevent stone formation include drug therapy, diet modification, and fluid intake, as we discussed. Thiazide diuretics can help to excrete more calcium, which if the calcium is too high, we don't want that because that can lead to stone formation. Let's see. Now, for hyperuricemia, patients who have a lot of uric acid in the blood, or chronic gout, they need drugs to prevent urate stones. There's a stone called urate, U-R-A-T-E. And so there are some certain things we need to do to stop these stones from developing. The drugs, this particular drugs tend to alkalize the urine because remember the urine is more acidic. So lemon or orange juice ingestion daily is given as a source of citrate, and that can prevent this from happening. Now, a desirable pH is between, what we want is between 6.0 and 6.5, and this is not to be confused with serum blood serum pH, which is 7.35 to 7.45. This is urine pH, right? Now, the normal urine pH is between 5.0 and 6.0. And so you want it slightly more alkalized. Let's see. Now, statins, what we use to lower cholesterol can also be used to lower a stone formation as well. Now, cystinuria or high levels of cysteine must be lowered by proper drugs as well, especially if hydration and urine alkalization are not successful. So these are a type of a stone that can develop as well. And so there's certain drugs to lower this as well. All right. Now, if there's one stone, then just fluid intake, an increase in fluid intake would be recommended. But if more than one stone, if the patient has more than one stone, then we want to recommend drug therapy at that point. I also want you to, I probably already referred to this, but take a look at table 6065, page 1365 for proper diet, depending on the stone formation, right? So take a look at that. Other measures to help patients to pass these stones. We want to encourage walking, which promotes stone passage. So help them to, or encourage them to ambulate. It also decreases bone calcium resorption. When we say bone calcium resorption, in other words, when you're walking, then calcium stays within the bone better. But the resorption here, it decreases calcium resorption. In other words, calcium coming away from the bones, especially for people who are not active, they're not ambulatory, they tend to lose calcium. But, and this is what the calcium resorption is talking about. So we want them moving. Also instruct patients to strain their urine daily and also check their pH as well. And we know what we want their pH to be. Also take a look at chart 66-11, page 1366, for education on self-management for your patients with respect to a stone formation. And folks, that would conclude this particular presentation. Let me see something though. So we got through quite a bit so far. I just want to look at something though. Hey, did you guys see my email about the dosage calculation quiz?
Yes, sir.
Yeah, those are fairly, they're fairly straightforward. I mean, I didn't do anything to throw you a curveball or anything like that. So you all should be fine with that. Pretty basic. A lot of them D over H, and of course, if you have a medication in grams and milligrams and they want you to convert to grams, then of course you have to know what the conversion is. It is a gram equals 1,000 milligrams and so forth. So you have to know your conversion factors. And I did give you quite a bit of time. It's should be due before midnight Sunday. And I gave you 2 hours to do. It's only 20 questions. And so, so make sure. Say again?
I didn't get the email.
You didn't get it?
No.
Oh, that's odd.
I just got quizzes open and that was yesterday.
Did anyone else get that email from me yesterday?
I
got it.
The quiz. It's under the HESI tile. It's not under our adult health tile, the dosage quiz.
Yeah, but did you guys get my email yesterday about it? Or did I send an email?
Yeah.
Uh,
You sent
Yes.
an email. We got it.
Yep.
Can you resend? I did not get it.
Go
They gone, Mommy?
the announcement.
maybe that's where I put it.
Okay, thank you.
Yeah, that's probably where I put it. Yeah, my apologies. But you still should have got an email if you have it set up that way. You know what? Because I sent an email to 1640, and I think I just did an announcement with you all.
I'm seeing it here in the announcement. Thank you.
Yeah, that's where they are. Yeah, I'm doing so much. I don't know whether I'm coming or going sometimes, but be that as it may. Yeah, so it is under the cohort. What else I just wanted to kind of look at something. So we did cover a lot that you'll see on your next exam, which will be on campus. I thought, let's see, kidneys, it was this one. So pyelonephritis, there's a voiceover on that one. I think there's one on, maybe one on that one too. Did I do one on nephrotic syndrome? Did you all get a question on nephrotic syndrome on your quiz?
Yeah,
You did?
actually,
We got a few questions on that.
2 or 3.
Oh. All right, so I need to move this. This is not for this section. So I need to look at it.
On Raynaud's disease. A lot of questions about that.
On what now?
Raynaud's.
Raynaud's.
Yeah, there was like 5, I think.
Yeah, there was a lot of questions about Raynaud's disease.
I wonder did I move my Raynaud's to that particular exam? Yeah, that's possible. Some of these all right, so I did do a voiceover on pyelonephritis as well as glomerulonephritis. So make sure you guys take a look or listen to those as well. And they're not very long at all, to be honest with you. Which is a good thing. I think the longest ones are like your cystitis. I mean, that can be a pretty long one. Yeah, so, all right. So what we would do as far as, as a matter of fact, you don't have to complete it, but the drugs that you work on today, even if you complete a few of them or whatnot, go ahead and I'm going to create a clinical tool. And so, even if you only get to a few of them or maybe a couple, I don't care. Just go ahead and submit it. I'm going to put it in week 4. Let's see, what is this?
I think it's one for Monday. Something.
What happened now?
Bellamy made a weekly clinical tool submission for Monday for us to submit our work from that. So it might have to be like different. Maybe it says like.
Yeah, looking at this one now. So this is module 4, and I want to get rid of this 2, and then I'll go ahead and put my name on it, so you'll know which one to submit it to. So if you all want to see if you can see it, it says module 4, clinical 2, and then Professor Weaver. I've often told you guys I would probably do grids, and some of you may feel more comfortable doing cards and whatnot. So even if you do cards, just take a picture of the card and of the cards and just upload it. And so we'll use that for your submission. Your endocrine is your next test.
I have a question. You said even if we just get to a few of them, and I see the module 4 clinical tool you just added. Is that for drugs, you said?
Yeah, it's just for the drugs.
Okay.
Yeah, no concept maps today.
Okay.
With this business with the CPR and all that. So I want to simplify things today.
Okay, thank you. Okay, wait, I'm trying to, exam 2, urinary medications. These are all the medications that are going to be on the exam coming up, right? 15.
Yeah, just like last term, nothing different.
Okay, thank you.
Yeah, so just make sure you guys do, because I think I mentioned in the notes what, for the most part, that I'm looking for. And so if you create, you should always create a comprehensive grid or cards where you talk about the classification, the indications and side effects and your nursing responsibilities and so forth. Are there any antidotes to be given? And also, what's that one? Should it be given, this is one column I would definitely add. Should it be given with meals, during meals, or after meals? What is this? Yeah, so I would definitely make my cards, kind of a more of an inclusive approach, so you don't miss anything. Because some questions do want to know or ask you, you take it with meals or after meals or during meals. So I would add that as an additional column. Let's see, what else? Uh, so you all did quiz. You know what? Let me see something. I just want to make sure I'm telling you something right. So you'll have exam 2 next week. Mm, those of you who are taking mental health, are you all getting enough EAQs so far?
Way more than enough, like beyond enough.
Is it affecting your ability to study for this class?
I think so.
Yeah, I mean, because we have, like, for her class, we have at least 300 EAQs to do a week.
Right.
At least, like, we're surprised if it's under.
Really?
Like that's crazy.
And it's so many where it's like you can't possibly just, you get so tired of it that your brain is just not accepting any more information anyways.
Right. It's overload, really.
So with
It
that
really is.
said, so does that mean you guys are? That's a question I wanted to ask you. So are you reading?
Barely.
Not really.
I'm gonna be honest. Like, I'll read the boxes and
I read.
as much as I can, but the EAQs take up most of the time.
I mean, are you all able to read with all the EAQs you're getting?
I read for your class, but when it comes to her class, I'm doing her EAQ so much that I don't have the time to read, like for the time I set aside for each class.
Right. All right. Well, I mean, obviously not a whole lot I can do about that. I mean, I have spoken with Director Wright about the EAQs, and she's actually in agreement with me that we need to minimize them as much as possible. Because as you all know, my big thing is you got to read, and so I feel like at least the fact that I've taken away a lot of them from my class, hopefully it hopefully kind of balances out, hopefully somewhat, for the most part, perhaps. So, but just try to find balance as you do them, as you work with both classes. Maybe one of these days they will kind of lower the amount of EAQs that are being done. I don't know when that's going to happen, but because I used to correlate doing a lot of EAQs with people doing excellent on the HESI, but that's just not the case. The reason why people do a whole lot better on the HESI is because we tend to provide you with the concepts concepts that you would have ordinarily dumped, but now you're able to view them close to the time that you have to take your exam. Excuse me, your final exam. So, anyway, just an FYI, this is not, you know, the best grid, but this is a kind of a grid that I will create. Like I was telling you guys, I would probably add another, let's see, insert column to the, yeah, so like a width, let's see, you can maybe label it food, you know, with versus without, or before, you know, something like that. And then, you know, of course, it may not even matter, you know, but with some of these drugs, I would definitely see if it does matter. And many of them, you can just Google it. It'll tell you if it's with or without food.
Well, I have something on that. The way you have it here, you have it all, you know, organized by specific like classification, drug, method of action, etc. And with the drug list that you sent us, there's just certain things about it that you want us to know.
You know, and I'll be honest with you, it's probably just one thing on there that I really want you to know, but I'll kind of make it a little more comprehensive because I need you to know more about it just in case. Because I may ask you about the mechanism of action for a diuretic, such as what you see here. But in actuality, I want to know what are the indications. But say if you take another exam somewhere else, NCLEX included, and it wants to know the mechanism of action, you know, or rather it wants to know, you know, something else, you know, maybe the side effects, maybe your nursing responsibilities, then I want to make sure you capture all that information. So it's like, just in case, I don't want to cheat you out of, you know, what you might really need to know. So that's why I do that. There may be some cases, all I might want to know is what's the antidote for heparin, you know? And I may include I may say, well, I want, you should know four different things or whatnot. And all I really want to know is about, I don't know if I should tell you that. I probably shouldn't have told you that. But all it means is you really don't know what I want to know as far as which one. It could be all, but it could be one. Could be two things from that list. So I say just go ahead and make your comprehensive drug grid, however way you want to construct it, and then go from there. You know, even if I don't ask you a particular question about it, then maybe NCLEX will, or maybe HESI will, or you may get asked in another class about it. Who knows?
Speaking of exam and drugs, with the conversation that you had to the class last week about possibly giving some points, I didn't notice any points added to the first exam. Is that something that you're not considering anymore?
That's because I haven't gotten around to it yet.
Okay, thank you.
Yeah. Yeah, well, not that it's you all's problem, but suffice it to say that there's a lot that's going on. Just taking over 1640 is a lot, and so I'm happy that I'm taking it over, but it's so time consuming. And so right now I'm dealing with a presentation about cancer, and it's like I've been working on this darn thing for like 3 days. And you all probably remember it when you took it last term. I mean, probably most instructors, they probably wouldn't have put in as much time as I'm putting into it. but it's only because I want to make sure you all, well, make sure they know, and I would have wanted to make sure you knew it too. So a lot of these things are playing into why things are so crazy right now. Hopefully I can get this thing under my belt and sort of kind of go back to business as usual, if that's such a thing. But at any rate, no, I haven't done that yet. I know I need to do it because I think there might be a couple on there that I know I might be giving some points away. Yeah, if you missed it, you know, provided you missed it. Let's see. Something I was going to, let's see if it's this one.
For our clinical tool, is that due at 5:30 or by end of day, like midnight?
With this one, if you can just turn it in before, well, yeah, I mean, you can turn it in before midnight if you want. I mean, like I said, it didn't necessarily have to be 100% complete. And so if you started it off, you know, you got through maybe a few and you want to post that, I mean, that's fine. Obviously, the onus is back on you to make sure you complete it, you know, for the purpose of being successful on your next exam.
Okay, thank you.
Sure. Any concerns as far as clinical next week?
We will be on at Atrium next Monday.
You know, I believe so. I think we all are going to clinical next week. That's why they're trying to really get in the what do you call it? The what do you call it? The CPR.
What do you mean all going to clinical?
What do you mean?
Who is all?
Who is all?
Yes.
I don't quite get what you're saying.
You said we are all going to clinical. Who is all?
I mean, is anybody excluded? I mean,
This
maybe
whole entire class on Wednesday is going to clinical too?
Say again?
It's really not that difficult of a question. I want to know if
you're not being very clear. If I told you that everyone is going to clinical, that means everybody. All means all. All doesn't mean some, it means all.
Right. I know we're going to clinical on Monday. So are we going to clinical on Wednesday too?
This is our last clinical for Wednesday.
Which I had already said.
Our clinicals are on Monday. This was just 3 times on Wednesday. So therefore, next Wednesday would be the 4th Wednesday, which means no.
I understand that, but he said we are all going to clinical. So I didn't know if there was one that was added.
He said next week and then next week Monday. Like,
Ooh, Lord.
Not Monday.
But
Ms.
I did have a question.
Ms. Ezra, you're making it more difficult than what it is.
I'm not. I asked a simple question.
You have clinical. You all have clinical next week. I also mentioned earlier that today was your last day of the 3 weeks that you're in clinical. That's why I'm saying to you, I don't understand what you're saying. So it was the onus was on you to be more clear. I thought I was being clear. No, well, you may be speaking English, but you're not clear on what you're saying. Because remember, you know what? Scratch that. Somebody else had a question? Ask me a question.
Yes. So next Wednesday, 10 to 1, is that going to be online or are we going to be on campus?
Next
Wednesday. Like next Wednesday, since we have to be.
your exams are actually on campus.
Okay.
Yeah. So I was trying to make your quizzes more online and your exams on campus. They want exams on campus.
Okay. So since next Wednesday is an exam, we'll be on campus, and then that following week is a quiz. So we may be online.
Yeah, you should be, and hopefully, there'll be a room. I mean, remember that was my plan last week, but the problem was there were no rooms.
Right. Okay.
Yeah, so hopefully they'll be able to give us a room. I mean, you guys are not a big group, so I don't know why it was so difficult to find a room, but it was. Hence the reason why we were flexible enough to just move on back to the house and do what we have to do.
And next
I have a
Wednesday, it'll be 10 a.m. instead of 8, right?
Oh yeah,
Okay.
and I'm happy about that.
Dr. Weaver, I had a question as well. I
Sure.
know we're trying to get everything together for the CPR for Monday, but if we do have to be on campus next Monday, can you send out an email just so we can be clear? Like, because I know the whole CPR thing is still up in the air.
Yeah, if they change anything, I hope Dr. Balance. Well, no, she's not going with you all, is she?
No, I'm pretty sure it's done.
No, it would probably be Dr. Bell or Professor Bellamy.
That's what I thought. Yeah, I'm sure she'll reach out to me, and if she does, I don't know if she has you all's email, but she does have access to the announcements. So just make sure you all are looking at the announcements. And of course, if I'm pretty sure she'll also contact me, and I'll let her know to just go and email you all as well. Let you know if there's any changes. I mean, I'm hoping they get you all through the CPR this week. But who knows? But there's a couple of you, or maybe a few, who's getting your CPR done today. So I'm assuming, and I hate to assume, but I'm assuming that should complete your group, as far as all the people that has to take it.
Yeah, they're taking it today, so unless something crazy happens, we should be good for Monday.
Yeah. What would they let one of you, if one doesn't do it, would they make the whole group sit out?
That's what if one can't go, then we
Yeah.
don't go.
They said that?
That's kind of what they insinuated, yes.
Oh,
Yeah.
Because they said there was nowhere to put them because most of the campus will be going to clinicals.
mhm.
So there was nowhere to substitute that one person for them to stay on campus.
Oh, well, you know what that means. Get it done today then, or today, tomorrow, or whatnot. All right. Now, how are you all coming on? Right, scratch that. Let's see. Let me tell you all something. I'm a grown man, and you all are grown women. When you talk to people with respect and not with a smart mouth. All right? If you dish it out, you got to be ready to take it, right? So if I'm telling you I don't understand what you're saying, an inappropriate response would be, I'm speaking English. That's not an appropriate response. All right? My name is Dr. Weaver. I have a doctoral degree. I'm not an ignoramus, if you understand what I mean. And so if you calm yourself down and ask me the question, obviously something I had already answered. If I'm telling you I don't understand, then you should be patient enough, mature enough, respectful enough to talk to me in that manner. All right? Because I'm telling you right now, you will have a hard way to go with me if you think I'm going to sit back and allow you to talk to me any kind of way. All right?
It goes both ways, sir.
You all know that I have spoken to you all very respectfully. Is there anyone in this classroom, excluding one, who will beg to differ, but is there anyone in this classroom that can say right now that I have disrespected them in any kind of way?
No, sir.
Nope.
No, sir.
You just disrespected me by
Not at
calling
all.
me out when we could have
Yeah,
discussed
yeah,
it.
I'm sure you would say that, but I have witnesses.
No, I
to-
don't think you've been
Yeah,
disrespectful. to
we have enough witnesses, and plus I'm recording the conversation. But
Okay, but I
I do
feel like
not-
I should have been addressed after class.
I do, well, you know what? When you address me, then what you should have said was, let's speak about this after class and not come at me in the wrong way.
I didn't come at you the wrong way. You
all right.
came at me asking, you didn't understand what I'm saying.
Is that a problem?
It is when I asked a simple question.
No,
Who is
ma'am.
we?
No, ma'am. No, ma'am. It's all about tone. It's all about
Who
tone.
is we? That's what I asked.
It's
Because
all
your
about
tone is the same.
It's about tone, Miss Zales. All right? You can ask things or say or make statements in such a way that people understand that you're not trying to be a smart aleck, all right? But you're sincere about, what you're trying to understand about a conversation, all right? Don't everybody understand something the way you put it forth.
Okay, well, my question was to you, not to anyone else.
We all speak differently. We all understand differently, all right, at times. And the proper thing to do was not, or the proper thing to do was to say, well, let me explain it another way. Come at another angle.
Well, I don't have, I feel like you have throughout last semester, and this is something that's inappropriate right now. We're wasting the students' time. This can be addressed after class.
It's time, right? Now you're concerned about wasting students' time. Again, I'm going to say, it is the way you speak to people. That's what's important here. And this is the problem that I'm having, is how you speak to people. Speak to people
Okay.
like
We
adults.
can discuss this with President Riley, please, because this is now, obviously, people are coming on camera,
We can
and
discuss
you're
it with whoever you want to
belittling
discuss it
me.
with. We can discuss it with whoever you want to discuss it with. But you're not going to talk to me any kind of way. This is my classroom.
I understand, but you're addressing me
Yes,
in front
and
of the class, again,
when you talk to me,
making your point that there
you
is
talk to me,
obviously
you talk to
tension
me
between
with
me and you.
you speak to me with respect, period.
Sir, we're both adults.
We are?
But
Well, talk
Melissa,
to me.
he had
Talk
the
to your son.
right to bring that to you right now, just because you brought it your way to him. So he needed to address
Miranda,
that
please.
and say, you know
Don't
what, I'm not
stick
going
up
to deal
for
with
him.
this
He
here.
has a history of this with me.
Well, that's fine, but if
What-
you have that problem with him, then you need to email him and not have that attitude in
Melissa,
class.
you
That's why
talk
he
to
addressed it
people
here.
rude.
Logan, stay out of
addressed
it,
here,
Logan. Don't
Melissa,
talk to me,
because
Logan.
you did it in front of the class. And I'm not saying that
Don't
to be
talk to me,
disrespectful,
Logan.
Listen, I don't do that.
but I'm telling you that because it's more important that you understand that he addressed it that way because you brought it that way.
I think
He's not
now
doing
that
it to be
everyone's making
disrespectful.
their
He's
point
doing it
and
to make the
showing
point
their
to
faces on
everyone.
camera, I think the professor here has accomplished his goal, which is to
Guys, I'm
create
just
more
coming into this,
tension
but why
against
is this a
me.
thing right now? Like, this is supposed to
Okay.
be a lecture. We're not supposed to be arguing
Exactly.
over
Thank
something.
you. I appreciate that, Kendall. Thank you. Exactly. My point.
Melissa, you threatened me. You've talked to people rude, so it is right for the
Logan,
professor to
stop.
bring up.
Stop it now, Logan.
Logan, just don't
Get
say anything more.
This
She's gonna
is
report
being
you.
recorded. Logan, do not talk to me. I've asked you that before. Now this is harassment, Logan. Stop it now.
Oh my goodness.
Can we get back to topic,
I noticed
please?
how the professor
Thank
is
you.
not making any you're letting them at me. You're not
Again,
stopping it.
when we address each other, it should be done in a way with respect. To tell someone I'm speaking English, that's not respectful. And if you think it's respectful, then I'll let you have that one.
I
That is not
am speaking
respectful.
English. A lot of people, including you, have made statements that you don't understand what I'm saying.
And so you approach me with, I'm speaking English. Is that
This
how you
is taking
approach
up
someone?
2 minutes of our learning time, sir.
Yeah, and it's my class, and I do with what I want to do with it. So what now?
I'm gonna dismiss myself and call President Riley right now. Thank you.
Take care.
Sorry, y'all, I had to deal with that.